So students, this is my fourth attempt to record. Something's wrong with the microphone, and so if I fixed it, you're hearing my complaint. Um, anyways, so chapter 14, complications of labor and birth. We're going to go through this quickly. Here are your learning outcomes for the chapter. If we have some time, I'll throw in chapter 13, which was the pain management of labor. So dysfunctional labor pattern, there is a hypertonic and a hypotonic, and most often we see the hypotonic, but you can see the hypertonic. Hypertonic dysfunctional labor pattern is strong, painful contractions, and they can be regular and often, but they're ineffective, meaning that they're not dilating the cervix. So a lot of times we will, if a woman is in a hypertonic labor pattern, she doesn't dilate, and we've tried everything, and then we may even call her a failure to progress, and go another route with her delivery. But apparently this recording is working because it would have shut down by now. So this is great. I must have fixed the problem. Anyways, so she has strong, painful contractions that don't dilate her cervix, okay? They're ineffective contractions. And most often than not, the problem with that usually causes this is a maternal malposition. So baby can be OP, occiput posterior, but it also could be a baby is in a transverse or a breech presentation where those contractions are just contracting away, but they're not changing the cervix because the fetal presenting part is not, if in a malposition, that fetal presenting part isn't getting on that cervix and dilating that cervix. In an OP position, you know, we can eventually get this woman to dilate in an OP position, but it just takes a lot longer and it's a lot more difficult. But anyways, what do we do to help a woman who's having a hypertonic labor pattern? Of course, we want to try to get her some rest. So we might do some sedation. We might do some pain medicine so that she can rest. We might get her an epidural so that she can rest, and then not feel those contraction pains. And then maybe even try to facilitate rotation of the baby to make the contractions and the fetal presenting part do a better job at dilating the cervix. And then really hydrate this woman. That could also help as well. So then if we get her some rest and pain management, then we can probably, like I said, rotate this baby either through an external version or change mom's position, or maybe get mom up and walk her for a little bit when we get her pain under control or something like that. And then hopefully those contractions now start dilating the cervix. Now, a hypotonic labor pattern is the contractions are less frequent, they're less intense, and of course that doesn't dilate the cervix. So this is really, I mean, so what's the difference between a hypotonic labor pattern and false labor? Well, the thing is, she has dilated her cervix. She is in active labor, but for whatever reason, she kind of stalls out and the contraction pattern kind of peters out, and then we have that problem. So what could cause those kind of things? Well, excessive uterine stretching or an overstretched uterine muscle, just like I talked about that one time about a uterus being overstretched like a rubber band, and it just doesn't want to contract well. So that's why we have postpartum hemorrhage, is that uterus just doesn't want to contract well. So what would cause this? Well, a baby that is so big that it's overstretched that uterus that when it's time to go to start contracting, those contractions are just really puny because that uterine muscle has just been too stretched to really contract well. Malpresentation, so transverse lie. it can also do this. Multiple gestation, so that's when there's more than one baby in this pregnancy, so twin or more babies. So when you have more babies in there, you have that overstretched uterus. Hydramnios is what we term too much amniotic fluid. So that also stretches out the uterus and causes that same problem. Grand multiparity. So multiparity, like we learned today, is a woman who's had more than one pregnancy. Well, grand multiparity is a woman who's had more than 4 pregnancies or more than 5 pregnancies. So lots and lots and lots of pregnancies, and that uterus has been stretched with each pregnancy, that it gets to a point where you can stretch that rubber band and snap it back into place so many times before it just doesn't want to snap back into place. It's just been overstretched. So that would cause a hypotonic pattern. If pain medicine is given too early, so that would slow down the labor, that would relax the muscles so much that they wouldn't contract well. So what do we want to do to help this woman so we can get this woman up and walk her and try to kick things back into an active labor pattern? We can change the mom's position. Of course, we can do relaxation techniques, but probably in essence what we're going to do that's going to make the most difference is augment her labor. So you remember I told you there was 3 different kinds of labor: spontaneous, induced labor, and augmented labor, and they're not always 3 different. So a woman can come into spontaneous labor and she can end up with a hypotonic labor pattern, and we would augment her. We would do something to help her labor along. That's augmentation. And so what are the things that we would do to augment her? We would either do Pitocin, like we would do if we just induced her labor, or we would break her bag of waters. Those are the 2 main things that we do to augment labor. Now, on the other side of the extreme is the precipitous labor and birth. A precipitous labor and birth is one that happens within 3 hours of it starting. And usually we actually time the 3 hours from the time they get to our facility. So, or get to the facility. So rapid, intense contractions, and then birth a baby, whatever centimeters she started at, so 0 or 2 or 3 centimeters when she started having contractions, to complete and pushing the baby out within 3 hours. Now, this kind of labor is super intense, super overwhelming, super painful, contractions one on top of the other. It just goes so fast and so powerful. These women, they come in and they want pain medicine and they want it yesterday, and we will do everything we can to get pain medicine on board, but sometimes we don't make it and she delivers the baby. So what can the nurse do about it? Well, there's really nothing that we can or will do to slow it down. We're just going to try to keep up. Of course, we're going to keep track of her cervical dilation and effacement. We might check her when she walks in, and then the next minute we know she's ready to push. So there might not be a lot of different cervical exams. You know, we need to be very supportive of the woman and the support person. So when the women come in precipitous labor, sometimes they're just totally out of control, which really freaks out the support person. And they're like, oh my gosh, what's happening? So do something. And we are doing something, but it's just a very high stress situation for this family. And they just kind of, sometimes they just kind of freak out. So she's having these overwhelming, intense contractions. They're one right on top of the other. And that baby is just flying down the birth canal. And she's just feeling this overwhelming urge to push. Now, in that situation, when baby's coming down so fast, and sometimes moms push, they can just shoot that baby out of their vagina like a cannon. And if they do that, they run the risk of blowing their perineum apart and having a really bad tear. So we've got to do our best to help the woman not push, and then when we do push, help her to do it in a controlled fashion so she doesn't shoot that baby out. And And then after she's birthed the baby, we're really going to want to do, or the physician is really going to want to look at that woman's vagina, not just her perineum to see if she's tore, but he's going to want to, the physician's going to want to look at the cervix. They're going to want to look at the vaginal walls, because as that baby comes shooting down, it could damage the cervix and cause tears in the vaginal wall that will all have to be repaired. And then we also want to look at the placenta. Did we get all of the placenta, or did we damage the placenta and maybe tear some placenta, and there's some placenta remaining after the birth, which would cause hemorrhage. So trauma to both mom and babe. We talked about some of the trauma for the mom, and she can indeed rip her perineum and cause severe damage to her perineum. So mom would have all that kind of trauma, but baby would have trauma as well. When baby comes shooting through that birth canal, baby's face, maybe head, can be bruised really bad. So we need to make sure that we check baby out. Now, fetal hypoxia. Well, if we only have a 3-hour labor, how bad can our baby get hypoxic? Well, if mom's having these really frequent, intense contractions, so like we talked about today, those frequent, intense contractions, they do constrict blood flow to the placenta. So, you know, that can really put baby at risk for severe hypoxia, okay? We already talked about uterine well, we didn't talk about uterine rupture. So with these super intense contractions, you know, that there is a risk for uterine rupture. But the perineal and the vaginal lacerations are more common. And then these women end up hemorrhaging because actually the uterus is like, what the heck just happened? Like, I'm shocked and stunned, and the uterus doesn't want to do anything. So contracting after a precipitous delivery sometimes is very puny, and the woman ends up having a hemorrhage. And then if she ends up having any type of trauma, she can have a hemorrhage from the trauma or some severe bleeding from the trauma. Okay? So that's those complications. Other complications that could cause us to do some interventions that could cause as much problems as they do help the woman, one of which is called an amnio infusion. So when we have a woman who's having, I think someone mentioned in class about meconium, and back in the day they did, I think it was Christy or someone had mentioned the amnio infusion was being done because their baby had the first bowel movement in utero and had meconium stained amniotic fluid. We don't do an amnio infusion for that anymore. We would do an amnio infusion, however, if we had severe recurrent variable decels and we still had quite a ways until the patient was completely dilated and ready to deliver. So we would do an amnio infusion to give more fluid in the uterus to cushion that cord to alleviate some of those variable decels. Remember, variable decels are from cord compression. So when we do an amnio infusion, we have to have that internal pressure catheter in the uterus measuring uterine contractions. And on that catheter, there is a port in which we can hook up IV tubing and hook it up to either normal saline or lactated ringers. Usually it's normal saline, and infuse normal saline into the uterus. This has to be a very controlled infusion. We can't just let it dump in, like the whole liter of fluid dump in 10 minutes, because we could end up rupturing the uterus. So we've got to do it at a slow rate. We can do it on a pump. We don't have to use an IV pump. I like to use an IV pump, and then I can hook it up to my fluid warmer, and we can do warm fluid, and we can just you know, give her a little bit of a bolus, like a 200 or 300 cc bolus, and then just a slow drip, like 100 cc's an hour or something like that, for a while until we alleviate the variable decels, and then maybe we can discontinue it for a while. Well, we would just disconnect the fluid. We probably wouldn't pull the catheter because we don't want to have to put it back in. So we would just continue to use the catheter. But anyways, so that's how we would do it. And then everything, we'd have to have accurate I&O on that infusion. So if we put in, say we put in 4 hours, say we put in 400 cc's in 4 hours, then we're going to want to know how much has come out. Like if none has come out, then we probably don't want to be putting any more in, because we don't want it just to keep filling and filling and filling and filling. We don't have to have cc per cc in and out, but we do have to see that we are getting some out, and we do want to keep track of that. So if we've put 400 cc's in, maybe we want to see 300 come out. Maybe we only want to see 200 come out. Maybe only 100, but we want to know what that is. So what we're going to end up having to do is weigh pads. So whatever pad she's on, we're going to want to know the dry weight, and then start the infusion. And then at some point in time, maybe in an hour or in 3 hours or in 2 hours or however many, we're going to weigh that pad and see how much fluid we have out. Now, there are risks for doing this procedure. Of course, there's infection. Even if we didn't do the infusion, if we just placed the intrauterine pressure catheter, that does increase her risk for infection. Okay, so if we didn't do good technique in introducing the pressure catheter, we could introduce dirty gunk up into the uterus, which could cause infection. The other thing is, even if we did great technique, that is an avenue for bacteria to ascend into the uterus. It can just crawl right up that catheter. So she's at risk for infection whether we're doing the infusion or not. Of course, she's at big risk for over distension of the uterus. You put all this fluid in there. If you're not getting any fluid back, you could just keep dumping fluid in there, and there will be a point at which the uterus will say, no more, and we could cause a uterine rupture. But how are we going to know if we have too much tension in our uterus? Well, remember that I said that the resting tone is when the uterine muscle is relaxed, and it's anywhere from 0 to 20. And if it's above 20, we need to know why, because that's telling us our uterus is not contracting. That our uterus is still contracting. It may not be contracting at the intensity of a contraction, but it's not resting. So we need to find out why. Well, one of the reasons why is because we're over distending it with an amnio infusion. So we need to watch our uterine resting tone. Okay. All right. Of course, we're still going to monitor intensity and frequency of our contractions. We're going to watch our maternal vital signs. We're going to educate our mom on this process and why we're doing what we're doing. An amniotomy is what we call an artificial rupture of membranes. It's when we break the bag of waters ourselves. So an amniotomy is us breaking the bag of waters ourselves. We call that an artificial rupture of membranes. If those membranes rupture on their own, like at the patient's home, or even if they rupture at the hospital, but it does it spontaneously, that's what it's called, spontaneous rupture of membranes. Now, we'll do an amniotomy like I said, to augment or induce labor. And we'll also do it if we feel we need to place internals. Remember that internal pressure catheter and the internal spiroelectrode to monitor baby's heart rates? Those can't be placed if her bag of waters is still intact. So we might need to do an amniotomy so we can place those. Now, when we talk about it augmenting or inducing labor, this is why. So it causes the release of this acid. Please don't make me pronounce it. And that acid converts to prostaglandins, which then stimulate the secretion of oxytocin. So breaking the water releases this acid, and it starts this cascade of events that causes pituitary and posterior pituitary secretion of oxytocin, which causes uterine contraction. So that's why we do that. The risk of doing that, we already know, is an umbilical cord prolapse, and it's also a rupture, it's also an increased risk of infection. So we break that bag of water. Now, if there's any bacteria or anything, it has a place to go and playground in which it does its damage, and that is in the amniotic fluid. So we watch for signs of infection, which are maternal febrile maternal fever, so anything greater than 100.4. If mom complains of chills, if we palpate our uterus like we do throughout our labor process, and she says that's feeling more tender, then that is a sign of uterine infection. And then if we have foul-smelling vaginal discharge, that's a sign of infection. And then if baby is showing fetal tachycardia on that heart rate tracing, that's also a sign of infection. So we need to watch for those things when we rupture membranes. So what we do is, of course, we watch for those signs. We monitor mom's vital signs. We do cervical exams, but we only do them as needed. We watch our baby's heart rates. Baby's heart rates will tell us what's going on, and then we'll monitor our contraction pattern. Now, when the water has broken, whether we break it or whether it breaks spontaneously, we need to document the amount of fluid that we feel like. So is it just a little trickle? Does it look like a big, huge bath, like a moderate or a large amount of amniotic fluid? What's the color of the fluid? So we want it to be clear, or it can be blood tinged. That's okay, but we don't want it to be green, any form of green, or look like it has green specks in it or green chunks in it. What's the consistency and clarity? Is it thin fluid that is clear, or is it kind of like cream soup, but split pea green soup, green color? And so that would tell us meconium. And then again, is there any odor? Okay. Now, a lot of women come in for induction and cervical ripening. So induction means that we use some sort of method to cause uterine contractions. We can do a chemical method, which would be our Pitocin, or we can do a mechanical method, which we will talk about mechanical methods to induce labor. But one of those mechanical methods is rupturing of membranes. Now, we don't just induce someone just to induce them. We hopefully have done some sort of assessment to determine whether or not their cervix is what we call favorable for induction, or whether she has an inducible cervix. So there are some assessments we can do of the woman's cervix, and based on our assessments, we fill in this little table and score the woman's cervix, and that will tell us whether or not she has a favorable cervix for induction. So what we're trying to determine is if we start labor, is that cervix ready to dilate? Okay, that's what favorable or inducible means. Is that cervix ready to dilate? Should we start doing things to cause labor? Now, the test that we do on the cervix is called a Bishop scoring test, and so a woman who has never delivered or had a labor or delivered a baby, she needs to get a score of greater than 9. If it's a woman who's had more than one baby, she needs to get a score of greater than 5. Hang on. So, what is the scoring? So this is the Bishop scoring. So when we look at our cervix, we assess our cervix, we want to know what is her dilation. And when you go across the chart there, we have dilation from 0 to 6 centimeters. So depending on what her cervix is, she will get the score that is heading the column above that certain dilation. So for dilation, if she has a cervix that's 4 centimeters, she gets 2 points. Now, we also determine effacement. That's the thinning of the cervix. So if we determine that this woman's effacement is 60%, she's going to get a score of 2. So now she has a score of 4. And then we're going to determine the station of the baby. And if her station is, let's say her station is -2, then she's going to get a score of 1. Now, the consistency of the cervix. How does the cervix feel? Very firm and hard, or does it feel really soft and squishy? So we're going to call her cervix soft. So she gets a score of 2. And then where is that cervix in her vagina? Is her cervix really posterior, so we have to, hike in about 2 miles before we reach that cervix? Or is that cervix anterior? Basically, we could look into her vagina and see that cervix looking us in the eyeball. So we're going to say her cervix is in the middle position or mid position. So that would give her a score of 1. So that's a total score of 8. So if she's a primip, a first-time pregnant woman, then if she got a score of 8, then, we really want her score to be 9 or above. So, but 8 is really close. So maybe, if we work really hard at convincing her cervix to participate, maybe we could get her to an inducible state. But if she was a multip, she got a score of 8. Remember, she probably is very inducible or has a very favorable cervix. Okay. So when we talk about getting that cervix ready for induction, we want to use cervical ripening agents. So these are a little bit different than induction agents. They're cervical ripening agents. They're not really causing labor, but they're trying to convince that cervix to be inducible. So these are the drugs that we would give to those women who scored low on that Bishop score that said that their cervix wasn't inducible or favorable. We might do some of these drugs to make that cervix inducible or favorable before we start the induction. So this usually takes place the day before or the evening before induction, and then maybe induction starts the next morning. So the two drugs that we typically use for induction, for cervical ripening, are Cytotec, our misoprostol, or Cervidil or dinoprostin. Okay, so do I have? So Cytotec is a medication that we give intravaginally. We can give it orally or sublingually or rectally, but we typically give it intravaginally to ripen the cervix. We do 25 micrograms, and these tablets come 100 microgram tablets. So we actually have to have pharmacy quarter this tablet for us because we only give 25 mics to induce or to make a cervix favorable. And we give this medication every 4 hours until they start having regular contractions. And usually by that time, the cervix has softened and released some chemicals that stimulate labor, stimulate contractions to start. And then once we get to that point, then we can follow through with the regularly planned induction and start Pitocin or whatever we do. So we give 25 micrograms every 4 hours until we get regular contractions. Once we get those regular contractions, then 4 hours after the last Cytotec, we can begin oxytocin. Okay. Now, just for a comparison, Cytotec, when we use Cytotec for postpartum hemorrhage, we usually give it rectally. We give up to 800 mics. So look at the difference in the type of and the dosage of that medication for those different uses. Now the next one is Cervidil. Cervidil is like soap on a rope. It is, it has that prostaglandin medication in this little mesh fabric. It's connected to a little string. We insert that vaginally in up by the posterior fornix behind the cervix, and we usually leave that in for 12 hours. And then after the end of 12 hours, we pull that out. We put the woman on the monitor. We do a non-stress test, or I'll tell you about those later. We'll do a test to make sure that the baby is looking good. And then 30 minutes later, we can start Pitocin. Okay? If during that 12 hours, the woman actually goes into active labor or her membrane's ruptured, we can just pull that Cervidil out and just go on with the labor. Okay? We don't use the gels. Okay? I've never used the gel in my 20-some years So I don't know who uses it, but I don't use the gel, so we're really not going to talk about it. Now, what are the contraindications to using these medications or ripening the cervix or being ready to do an induction? Well, one is a non-reassuring fetal heart rate. So if you already have a baby that's showing you that this baby is under stress, are we going to add more stress to it, like getting this woman ready for labor? No, I don't think so. Maternal fever, maternal infection, vaginal bleeding, we will not do these agents in those cases. A hypersensitivity to the drug. If the woman's already got a regular contraction pattern, we cannot use these medications. If she has a history of a cesarean birth, we can, or a uterine scar, she would have a uterine scar because of some sort of uterine surgery not related to a cesarean section. So maybe she had a tumor removed or a fibroid removed or something like that. If she has a placenta previa, we would not be doing these medications. Or if she has a uterine rupture, of course, we're not going to do these medications. I will tell you what a placenta previa is, and we'll talk more about uterine ruptures in a moment. Okay. Now, non-pharmacological ways that we can make the cervix favorable is these mechanical methods. And these stimulate the release of prostaglandins, and you remember prostaglandins stimulate the secretion of oxytocin. So cervical ripening balloons or a Foley catheter balloon. So what these are these catheters like a Foley catheter, and they have balloons in the tips, just like the Foley catheter does, that we can inflate. And a cervical ripening balloon, I really love them because they have two balloons as opposed to a Foley catheter balloon, which is only one balloon. So a cervical ripening balloon, you stick this catheter up in through the cervix. Okay, the cervix really doesn't even have to be dilated. You can push this little catheter through this cervix, and then it gets into the uterus. And then what happens is we're not going into the amniotic membrane with this, okay? We're just going into the uterus. We're not going into the amniotic membrane with the baby. So we go up into the cervix, right through the cervix, and we inflate a balloon, okay? That's the uterine balloon. And then on the other side of the cervix, in the vagina, is another balloon. We inflate that balloon. Those two balloons create pressure on the cervix and cause the cervix to soften and swell and break down the collagen fibers and release these prostaglandins and hopefully prepare, get ready for labor. Now we leave these in place typically for 12 hours. A lot of times we can, I know physicians, they don't do it. I don't believe anybody does it here in Missoula, but I know physicians in Wyoming who put these in the OB office and send the patient home and then tell the patient to come to the hospital in the morning for induction. But usually we put these in the hospital. We leave these in place for usually 12 hours and then we take them out. Now, if the woman responds really well to these, then she starts to dilate, and then a lot of times these fall out. And if they fall out, she's probably dilated to 3 to 4 centimeters, and we can just start with labor, okay? If we just use a Foley catheter balloon, we do have to put that Foley catheter in through the cervix. We have to inflate that balloon. And you really can only get 10, maybe 15 cc's in that balloon or it'll burst. There may be Foley catheters have bigger balloons, for patients who've had some sort of bladder surgery or TURP or something like that, where they're 30 cc balloons. But you put those in, and then when you get those balloons inflated, then you tug on that catheter, pull tension down on it so it puts tension with that balloon onto the internal cervical os, and then you tape it to the leg. Okay, so that's what creates the tension. Anyways, another mechanical method is we can do an amniotomy, which means breaking the amniotic fluid, doing artificial rupture of membranes. The other thing that the OBs do in the OB office is they do membrane stripping, or strip her membranes. The patient will say the physician stripped my membranes. But what that means is they, by rubbing their fingers around the bag of waters, kind of rubbing them together, that helps release some of those hormones that could stimulate her to go into labor. Nipple stimulation is another thing people can do, is they do nipple stimulation. The thing with nipple stimulation is it sends a signal back to the posterior pituitary to release oxytocin. What this is simulating a baby breastfeeding. And when a baby breastfeeds, it stimulates the release of oxytocin, which causes contraction as those tiny little alveoli in the breast to let the milk down, okay, to squirt the milk out of those glands, out of those alveolar ducts, and so same thing. It'll cause oxytocin secretion and maybe start contractions, and then intercourse, okay. So intercourse can also stimulate contractions, okay. So those are the mechanical methods for induction or cervical ripening. So the chemical or the meds that we would use to induce, the one we will use is oxytocin. So we do produce oxytocin. It's produced by the posterior pituitary gland, and it stimulates uterine contractions. Oxytocin, Pitocin, so they're both the same thing, but you'll also hear it called, we're going to start her pit, short for Pitocin. There is a checklist that we need to follow when we start and manage Pitocin. Basically, it's their protocol. Is it safe to start Pitocin on this patient? So we need to know what the contraction pattern is. We can't start Pitocin if this woman is already having those 5 contractions in 10 minutes, remember? And then do we have a reassuring fetal heart rate pattern? And then as long as we can have those, we can go ahead and start the Pitocin. Now, we have 30 units of Pitocin in a 500 cc bag, and that will convert to us. When we want to start our Pitocin, we usually start our Pitocin at a 2 milliunit or 2 cc rate. It's 2 milliunits per minute, but it's 2 cc's per hour. So when that Pitocin is mixed in that bag of fluid, when we want to run 2 milliunits per minute, it is equal to 2 cc's per hour as the drip rate on the IV pump. So every 30 minutes, we'll reassess our fetal heart rate, we'll reassess our contraction pattern, and if we meet the requirements, we can up it. We can up the Pitocin another 2 milliunits or 2 cc's per hour, okay? What our plan is to get to a contraction pattern of 5 contractions in a 10-minute period, okay? We want the contractions to be 45 to 90 seconds in a 10-minute period, okay? So we can increase our Pitocin every 30 minutes to do that. Now, also that checklist or that protocol tells us what to do if we run into problems. One of the problems is tachysystole. We get too many contractions. We get more than 5 in a 10-minute period. So what do we do if that happens? Well, we just take the rate that we're running our Pitocin and we decrease it, we cut it in half. So if you've got your Pitocin running at 10 milliunits per hour, that's your drip rate. I'm sorry, 10 cc's per hour, that would be 10 milliunits per minute. If on our IV pump it says 10 cc's per hour and we have tachysystole, we would decrease it by half. So what would that be? That would be 5 cc's per hour. So we would drop our infusion rate in half. Now, if we had fetal heart rate problems, either with that tachysystole or even if we didn't have tachysystole, if we had fetal heart rate problems, we turn the Pitocin off. Period and end of story. And then we do our intrauterine fetal resuscitation, which is poisoning our patient. And then if we make our baby better and we want to restart our Pitocin, if we make our baby better within 30 minutes, we can restart our Pitocin at half of what the rate was when we turned it off. So again, if our rate was 10 cc's per hour and we restart our Pitocin within that 30-minute time period, then we restart our Pitocin at 5 cc's an hour. However, if it takes us more than 30 minutes to resuscitate our baby, then we have to completely start the protocol over at 2 milliunits per minute or 2 cc's per hour. Okay? Please write down your questions, because I can just picture me up in front of you guys lecturing, and you guys are great at asking questions. So I know you have them, so please jot them down. Now, considerations for induction, we get informed consent. Well, actually, not really. We don't get the typical surgical informed consent where we have the patient sign. Some facilities do that. I don't think St. Pat's does that, but I definitely know that Community does not do that. But some facilities have the patient sign a consent to start Pitocin or an induction. Of course, we're going to do careful monitoring. If they're on Pitocin, they're actually on continuous fetal monitoring. Okay. We're going to talk to our patient about pain relief measures because, you know, labor is painful enough, but then when you add Pitocin that causes frequent and more painful contractions, patients probably definitely going to want to know what her pain relief options are. We will certainly do position changes to help with her comfort. We'll support the woman and support the support person as much as we can throughout the whole process. Now, when a woman's on Pitocin, I said she has to be continuously monitored, but that doesn't mean she has to stay in the bed the whole time. She can get up and walk around the unit. She can get up and get in the bathtub. She can pace around the room. She can sit on the birthing ball. We have telemetry, portable fetal monitoring units that the woman can use if she wants to get up and move around. So that doesn't mean she has to stay in the bed. We talked about instrument-assisted delivery, so where we use the forceps and the vacuum. The reason why we would want to use that is it shortens the second stage. You remember the second stage is when she's already made it to 10 centimeters, and now she's going to push the baby out and birth the baby. So it shortens that time frame. And one of the things is we have a baby that's having some really bad heart rates. We know that mom's pushing, but it looks like mom's going to be pushing for another, I don't know, 10, 15, 30 minutes. And we don't feel like baby has that much time. We need to get that baby out in a few minutes. So we'll use forceps or the vacuum to do that. If the mom's totally exhausted and says, I just can't push anymore, I just can't do it, we can help her out with the forceps, okay? Same thing with poor pushing. And then if your patient has cardiac history, we might use forceps or a vacuum to help with her pushing because of cardiac decompensation that we sometimes see with a woman who does have a heart history, okay? And then again, I said baby, you know, if the baby is having problems, if the baby's not rotating down in there good enough, if the baby is a little bit crooked, the baby is head down but a little bit crooked, we could place those forceps and straighten that baby out a little bit. The baby must be vertex, in other words, head down. Baby must be engaged. ROM is a bag of water's rupture of membranes. They have to have rupture of membranes, and there can be absolutely no CPD. That's cephalopelvic disproportion. Cephalic meaning baby's head, pelvic meaning mom's pelvic, disproportion. Basically what that means is a square peg through a round hole. There can be none of that. We may end up cutting episiotomy to provide more room to get these forceps in and do this procedure. Now, what are the risks for us doing this? Of course, we're going to cause a lot of perineal trauma. And if we cut an episiotomy, chances are we're going to make that episiotomy extend into a worser tear. We could cause cervical and vaginal lacerations. That's a huge risk. We could injure the bladder and the rectum. We could injure the baby's head and the face. We could cause a cerebral bleed, a cephalohematoma. We could cause all kinds of bad, seriously bad things to this baby. That's why it's so important for the nurse to make sure that the physician is absolutely following the correct way to do this. Now, I don't mean to say that physicians are absolutely reckless, but, you know, there are some physicians that I have caught doing this inappropriately, applying too much pressure, And and we've had deliveries of babies, even if it's done correctly, that have a little bit of facial trauma. That does end up healing, but still, nonetheless, it's painful. Okay, so we've got to be very vigilant. Here are what the forceps look like. Okay, they're metal blades. You can see when you look at this perineum how big these metal blades are. And then you can see from this picture the correct placement and gentle traction with pushing. Okay, it helps bring that baby out. Okay. Now, vacuum assisted, you guys got to see what the vacuum looks like. That vacuum has come a long way since the day I started. When we did vacuum assisted deliveries, the vacuum was pushed on a cart. That's how big the contraption was that we used. It just looked like a torture device. But anyways, this is a little petite looking, sweet little thing. However, it can cause a lot of damage to baby as well. But anyways, we use it for basically the same reasons. And mom has to be vertex. She has to be ruptured of membranes. There can be no CPD, cephalopelvic disproportion. We have less maternal trauma using the vacuum because actually the head needs to be a little bit lower for us to apply it than it does for the forceps. But as I showed you, we pump up that suction and it can only be in the green zone, and we apply gentle traction with pushing efforts. And like I told you, the physician has 2 pop-offs and they're done. So that's your job to make sure that that's being followed. This vacuum here is an older style vacuum. It's a Bell style vacuum. But the same principle applies to its use. And then when we see in this picture in baby B, it can cause, even the flat one that we use can cause a little bit of this edema. And hopefully that's all that is. Hopefully that's just edema, tissue edema, and not hemorrhage. Okay. All right. Now, quickly moving on. Other maternal complications, hypertensive disorders. There are a lot of hypertensive disorders in pregnancy. Preeclampsia is the main one that we see most often. Eclampsia is a more severe, it's a more severe aspect of preeclampsia. Basically, it's preeclampsia with grand mal seizures. So eclampsia is when the patient now has grand mal seizures because of her blood pressure, hypertensive problems. HELLP syndrome is another progressive sequela of preeclampsia. HELLP syndrome is a mnemonic that stands for hemolysis, elevated liver enzymes, and low platelets. So what happens is as we start having preeclampsia and we start having vasospasms and epithelial damage in the vascular level, that is causing damage to our red blood cells. So we're having hemolysis. Now, because of this hypotensive disorder, the damage to our vasculature, that's going to cause damage in our liver, and we're going to see that from as evidenced by the elevated liver enzymes. Okay, and then low platelets. As we start having this vascular damage and those platelets are trying to attend to that vascular damage, and we're just going to start using up our platelets, okay? So that's what this syndrome is called. This is a very severe form of preeclampsia, and patients need delivered right away if they develop this. So we are going to be monitoring for this with all of our preeclamptic patients. Now, I haven't defined preeclampsia yet for you, and I will do that in a moment. The one thing that we're going to do to evaluate for preeclampsia and HELLP syndrome is we're going to monitor our lab values. So we're going to look at our CBC. Our CBC is going to tell us our red blood cell count and our hemoglobin and hematocrit. It's also going to tell us our platelet count. We're going to do coagulation studies to see if we're starting to have any clotting problems. We're going to look at our metabolic studies and our liver function studies that are going to tell us if we're having any elevated liver enzymes, so we now have liver involvement. We're going to look at our electrolytes and then help us determine if we're having any, if we're now affecting our kidneys or having renal involvement. So we'll look at that as well. And if we are having problems with HELLP syndrome, you know, we might have with low platelets, we might have to administer platelets to manage this patient. So of course we're going to be doing ongoing education, and then I'm not crap. I gotta grab my textbook real quick. It's just a few steps away, I think. Wait a minute, where is it? It's just a few steps away. So please. Give me a second. Okay. I've got it. All right. 518. What's on page 518? 518. Box 14-4. Oh, okay. So, so this is the management of a patient with preeclampsia. It talks about what we do to watch her blood pressure, what medications that we may be giving her. It will tell us about our renal assessment, our neurological assessment, our pulmonary assessment. Those are the really important things. Advancing signs and symptoms of worsening preeclampsia, seizures, and then also monitoring our fetal heart rate. So I'm really kind of surprised. I guess we're going to be covering this more at another time. And that's in chapter 11. So preeclampsia is it's a progressive disease, and they're not 100% sure why some women have it and some women don't. They do feel that it is related to the placenta, so whatever the placenta does that causes all this, they don't know. But basically, the reason why women have hypertension is because they're having, whether it's because of the hypertension or whether this is causing the hypertension. So we have vascular damage, epithelial vascular damage, and vasospasm. When we have epithelial vascular damage, we have leaking of fluid into the interstitial, so we have third spacing going on. And when we have vasospasms, that is contributing to our hypertension. Now, like I said, this is a progressive disease. So as we're having these vascular issues, we have vascular areas in our brain, in our liver, in our kidneys, in our lungs, and that's why when we look at table 14.4, that's why we look at some of these areas. Like that's why we look at our renal balance and what's going on with our kidneys. Is our preeclampsia affecting our kidneys? That's why we look at our neurological status, because we want to know, are we having vascular problems in our brain, which is going to cause some neurological changes. That's why we look at our DTRs and our clonus. Same thing with our lungs. We have vascular areas in our lungs, and if we have damage to those, to our vasculature in our lungs, then we're going to start having pulmonary problems. We listen to our lung sounds. Now, remember when I said we have vascular damage, which causes us to third space, so we see a lot of edema. We can see the edema in our hands and our feet and our face. We can also see that edema in our lungs. As we have vascular damage in our lungs, we have third spacing in our lungs, which is pulmonary edema. If we start having in those advancing systems in that symptoms in that table, if we start having headaches, blurred vision, that is affecting our brain, and we're going to see signs and symptoms in our with blurred vision and headaches. Also, severe right upper quadrant pain or epigastric pain. That's going to show that that's also another thing that shows us that we're having liver involvement. So if they're having right epigastric pain, then that is probably they're having pain referred from the liver, and so we know we're having problems there. Restlessness are all indications of the worsening of preeclampsia, which could mean that we're progressing to eclampsia, which means that we could be at risk for having a seizure. Now, when all those things are happening to the maternal vasculature, they're also happening to the vasculature in the placenta. So our baby is going to be having decreased oxygen and decreased nutrients because of that. All right. So that's basically preeclampsia in a nutshell. When we do our lecture on chapter 11, we will talk more about preeclampsia. Okay. Now, maternal diabetes is another complication that pregnant women can have, of course, whether it's overt diabetes or whether it's gestational diabetes. It does affect fetal lung maturity. So those high glucoses affect fetal lung maturity and actually inhibit fetal lung maturity. So that's what the problem is for the baby. Also for diabetes, the problem with the baby is they can be large for gestational age, which can present some problems when it relates to the birth, the actual birth. And then it can present neonatal, so the baby's already been born, neonatal blood sugar problems. But if our patient in labor has diabetes, whether it's overt diabetes or gestational diabetes, we might need to be managing her blood glucose levels. We might need to be doing it depending on her glucose control. We might need to be doing it every hour and while she's in labor. And then also some women may need to be on a continuous insulin drip during labor and therefore definitely need hourly blood glucoses. Okay. So we will try to induce these women. And then some women, especially if they're really worried, if the physician says, you know, like your baby is super large, I'm really concerned about an induction being successful, this woman could choose to elect for a C-section before ever going through labor. Now, this upright and side lying position, so definitely a woman any pregnant woman should be in a side lying position most of the time. But upright is also a good position, especially if she's diabetic and has a large baby, and get that baby off her diaphragm. But after birth, we're going to encourage breastfeeding. That dramatically reduces their blood sugars and reduces their insulin need at that point. Okay. All right. So some fetal complications, of course, we've already talked about fetal malpresentations. So your breech baby or your transverse baby, we can attempt to do a version, an external version. So an external version is where from the outside of the body, they try to manipulate the woman's abdomen in such a way to turn the baby into the correct position. This is quite uncomfortable for the woman, and it has its own risk factors we could cause. So we usually do these external versions at 37 weeks. So we could actually cause preterm labor by doing this, or we could cause a uterine rupture, or we can cause a placental rupture. So there are risks for this. But most often these are pretty benign. Now, an internal version is usually what we do for twin pregnancies, and the woman wants to do a vaginal birth. So what happens is both babies have to be head down to do a vaginal birth, but a lot of times that second baby is not head down. A lot of times that second baby is breech. So the first baby they deliver vaginally, the baby's head down, and then the second baby they determine is breech. So an internal version is they go into the uterus, up in through the vagina, through the cervix, into the uterus. They grab a hold of that baby and they turn that baby to head down. That's an internal version, okay? Another complication for baby is shoulder dystocia. We talked about that on our sim days, so I'm not going to cover this again. Cephalopelvic disproportion, I mentioned that in a few slides earlier. So that's when the cephalic, or the head, and the pelvis, the mom's pelvis, are not proportionate. Therefore, the baby can't fit through there. It's like putting a square peg through a round hole. It's not going to happen. Multiple gestation is another complication. It's a high-risk labor and delivery situation. So if she has more than one baby in that uterus, we can labor that woman in a regular labor room. But when she gets ready to birth or push, that patient has to be transferred into the OR. The reason why we do that is because sometimes the high need for that second baby to be delivered via cesarean section were already in that room. So that's a protocol in most hospitals, that multiple gestations will be delivered, even though they're vaginal deliveries, that they'll be moved to the OR to do that delivery. And then, of course, we talked about all the non-reassuring fetal heart rate patterns. Those are complications of labor and birth. Amniotic fluid complications, there's the two kinds here that are the most common: oligohydramnios or hydramnios. Oligohydramnios is there's not enough amniotic fluid. Hydramnios is there's too much amniotic fluid. Oligohydramnios is quantified as less than 300 cc's of amniotic fluid. They determine that via ultrasound. And the reason why we have oligohydramnios most of the time is because of renal abnormalities, because it is the fetus who produces amniotic fluid, and they produce that through their urine output. So if we have a baby with kidney problems, then we're going to probably have low amniotic fluid. Poor placental perfusion, so just like an adult that's not getting adequate blood flow to their kidneys, their urine output is going to decrease. Well, same thing here. If we have poor placental perfusion, we're not getting enough oxygen, then we're not getting enough oxygen, baby's not getting enough oxygen to their kidneys, so therefore they're going to produce less urine. If we have a premature rupture of membranes, well, of course, if your membranes rupture, you're going to have less than, and it's preterm, so we don't consider you being term and in labor and your amniotic fluid volume. I'm sorry, if you're term and you're in labor and your membranes rupture, we don't then say that you have oligohydramnios because your fluid is leaking out. But in the preterm patient that has a rupture of membranes and not in labor, remember I told you that we could keep these patients as residents in our facility for a while in this state, and so they will have only a little bit of amniotic fluid, so this could cause problems. Now, in the preterm patient, we will not do an amnio infusion, okay? That's contraindicated, actually. But in the term patient, we can do the amnio infusion, and we already talked about that. So the one big problem with little amniotic fluid is the cord compression. We don't have that amniotic fluid to cushion the cord and prevent compression. So we will see cord compression, which we see that as variable decels being traced on the fetal monitor. Now, hydramnios is too much amniotic fluid, so that's quantified as more than 2 liters of fluid. A lot of times we see this in multiple gestation. Now remember, I said the fetus is the one who produces the amniotic fluid, so if you have more than one baby in there, you're going to have more amniotic fluid produced, correct? Correct. Fetal anomalies can produce more amniotic fluid, maternal diabetes, fetal malpresentations, fetal malpresentations, prolapse cord, and a premature rupture of membranes are all risk factors for hydramnios. So if you have too much fluid in there, you have the opportunity for the baby to really just be swimming around this Olympic-sized pool, and therefore when you go into labor, you have a baby that's not positioned correctly because they've just been swimming around this big old pool, okay? Like we said, prolapse cord can be, prolapse cord is a risk factor for too much amniotic fluid. So when we break that water, we have this whole gush of, this big tub of fluid being rapidly washed out of the uterus, and of course prolapse cord could occur. And then premature rupture of membranes, because it's just the weight of that hydramnios can cause the amniotic fluid membranes to rupture. And so one thing that we might do to help this patient is fluid reductions. And we had a patient who had a severe hydramnios, and we did fluid reductions on her twice a week. I think they pulled 1 liter out of her twice a week. So it just kept generating more fluid, and it was an unsafe amount. She was a patient in the hospital for several months, and we did this amniotic fluid reduction through amniocentesis. So an amniocentesis is where we put a needle through the woman's abdomen into her uterus and into a pocket of fluid, and we aspirate that fluid. And then we pull the needle out. Those are fluid reductions, and we can do those in the hospital. Okay, another complication is meconium. Meconium stained fluid. So meconium is the baby's first stool, and usually they have these on after they've been delivered. They'll have their meconium for 3 or 4 stools, and then they'll start transitioning to regular looking stool. But if they have meconium in utero, that means that our baby has been stressed in utero, and that causes a vagal response where the anal sphincter relaxes, and meconium is the baby loses meconium in utero. So the big thing we're worrying about is when this baby is delivered, is this baby going to aspirate that meconium that it's been floating around in the amniotic fluid? And so when babies are born, we want to see, even with meconium stained fluid, we want to see this baby vigorous and crying. That means that they didn't aspirate anything into their lungs. If not, we bring the babies, I spelled visualize wrong, but we bring babies to the warmer. We put them on the warmer. We intubate the babies so that we can visualize the vocal cords to see if there's any meconium there. And if there is, we suction it out. And we try to do this before the baby's first breath. Now, this is in your textbook because this was the standard of care. But recently, in the past 2 years, this has changed. So we no longer bring the baby to the we no longer bring the baby to the warmer and try to suction this baby out before it does its first breath. Okay. So anyways, we figure that if baby was going to aspirate, baby did. So we just try to stimulate and get this baby crying, and go from there. Nuchal cord is another complication. So that's when the umbilical cord gets wrapped around the baby's neck in utero. And so as contractions are happening, and those contractions are pushing the baby down into the birth canal, that nuchal cord, that cord around the baby's neck, can start getting tighter and tighter. And so we'll start seeing probably variable decels. But then when the baby is finally birthed, we let them birth the baby's head, and then we gently try to palpate around the baby's neck to see if there's a cord. And if it is, we try to loop that cord around the baby's head and release that nuchal cord. But sometimes that cord is around the baby's neck so tight, we can't loop it around the baby's head. So what we need to do is we need to try to squeeze in clamps, 2 clamps, and we try to clamp the cord while it's around the baby's neck, and then we cut the cord in between the clamps to release that nuchal cord and get the baby delivered. Okay. Other complications. So here's our placental complications. So you've heard me say the term placenta previa. What placenta previa means is the placenta is covering the cervical os, and that presents a major bleeding risk for patients. So the placenta is a very vascular organ, correct? And usually that placenta is anterior, is at the top of the uterus and towards the back of the uterus. That's a great place for the placenta. But sometimes, in some cases, for whatever reason, the placenta is not back there. It's down there over the cervix. And so, one, you can't birth a baby through that placenta, or you'll damage the placenta and they'll both hemorrhage to death. But the other thing, what typically happens is that that placenta is over that cervix. And as that cervix dilates, it exposes more placenta, or exposes more of the vasculature of the placenta, and that vascular just bleeds. Okay. So depending on where that placenta is in relation to that cervix, some are completely covering the cervix. Some placentas are just down there low, close to the cervix. And so sometimes women can deliver vaginally with a placenta previa if it's just a low, a low-lying placenta. But if it's covering the cervix, she can't deliver vaginally. She needs a C-section. All right. Next complication is a placental abruption. This is where the placenta abnormally detaches from the uterus. When that happens, that place where it detaches bleeds. Okay. There's partial detachments. There's complete detachments. We'll talk about more of this in chapter 11, but a partial abruption is just when part of the placenta comes away from the uterine wall, not all of it. And so that part that has broken away, if that would clot off and stop bleeding, that would be great. We can continue the pregnancy. But if it doesn't, and if it continues to bleed, then we might have to induce her labor, cause her to deliver vaginally, or do a cesarean section if the bleed is bad enough. Like, for instance, with a complete abruption where it completely tears away from the uterine wall, that's going to be a massive bleed, and so we probably need to go straight to cesarean section. Now, the covillary uterus is bleeding into the uterine wall. So one of the things that happens is we have a partial abruption. It's the center of the uterus. So it's at the center of the placenta. So the outer area of the placenta is still adhered to the wall, but that center part of the placenta is not adhered to the uterine wall, and that part bleeds. So it can either bleed a little bit and cause enough bleeding that it actually tamponades itself and clots itself off, or what can happen is it can continue to bleed, and that bleed can be pushed into the uterine wall, and actually then it starts constricting all the vessels that are in the uterine wall and causing asphyxia or anoxic injury to that uterine wall. And so if you was to see that uterus, it would look all blue and dying, and which it would be. Those are bad complications. Now, someone asked about DIC today. So this is another humongous complication. I don't know why they have it in placenta problems, because this can be related to severe preeclampsia. This can be related to severe infection. This can be related to a severe hemorrhage. So it's not really just a placental problem. And it's not really just an OB problem. It's a severe sepsis and hemorrhage problem. So that can happen in any population. But what happens in general, there is a widespread bleeding and clotting going on in the body. So we have this massive bleed, which triggers the release of a lot of the clotting factors. All these clotting factors are being released to go and handle this bleed. But the thing is, the bleed is so massive that the clotting factors that we're spitting out aren't enough to handle the bleed. So we don't stop the bleeding, but yet our body is still rapidly trying to produce all these clotting factors, that eventually it gets to the point where we can't produce enough of these clotting factors, or we can't produce mature enough clotting factors. So what we end up having is these split products that end up causing microclotting at the microvasculature, although we're bleeding at other sites. So we're actually bleeding and clotting at the same time. So this is a very fatal syndrome that needs to be corrected immediately. We've got to treat, one, what is causing this bleeding. We've got to get that under control. We're going to have rapid and massive fluid replacement, and then we're going to need to give blood products. And essentially, we're going to be giving the main clotting factors that we need to get mature and adequate clotting going on, and then we can also then start hammering with red blood cell products, okay, packed red blood cells. But we've got to get this correct clotting under control, okay? All right, so it's a crazy thing. Other complications are a uterine rupture. So this is where the uterine muscle tears, and then this can end up in a massive hemorrhage. It is an obstetrical emergency. When a woman has a uterine rupture, it's severely painful, of course, as you can imagine, and then she has massive bleeding. Her risk factors for having a uterine rupture is a previous cesarean section. So this is why people that want to do a vaginal delivery after a previous cesarean section, this is why some people get really crazy about letting these women do this, is because uterine rupture is a huge risk factor in allowing that to happen, okay? So there's some other risk factors listed there. So if we have a woman with a uterine rupture, basically she's having a hemorrhage, we're going to manage her like we're having, like we would manage anybody who's having a hemorrhage. We're going to give them massive fluids. We're going to give them massive blood products. Of course, you're going to put oxygen on. We're going to repair that uterus. So basically, they're going to have to go in and do a surgical repair of that uterus. But if it's massive enough, if the uterine rupture is severe enough, they might not be able to repair the uterus. They might have to actually take the uterus out. That's a hysterectomy. Okay? Another complication, and I don't see this very often, is uterine inversion. It's where the uterus gets turned inside out. Basically, like if you can think of the uterus, so if you can think of the placenta being attached to the uterus, okay, and we're pulling on that umbilical cord to pull that uterus, or I'm sorry, to pull that placenta free after the birth of the baby. If we do that too much before the placenta has time to normally break away from the uterine wall, we can basically, with that placenta still attached to the uterus, we could basically pull that uterus out, and you could see how that would turn inside out, okay? We could do that with vigorous fundal massage. So someone asked today, can you fundal massage too strongly? Well, typically you can't do it too strongly, but if you did do it too strongly, you could possibly cause a uterine inversion. Uterinectomy, macrosomia, macrosomia is a large baby. These are all precipitous labors, uterine malformations, or incorrectly formed uterus, abnormally adherent placenta, so that placenta won't break away. Those are all risk factors for causing a uterine inversion. It's painful. It does cause bleeding. So what do we need to do? Well, one, we need to put the uterus back up in the body and put it up in there the right way. We need to give oxytocin to help that uterus contract, and then probably give the woman antibiotics, because that's a risk for infection right there. We've already talked about umbilical cord prolapse, so I'm going to move through that one. Variations in the umbilical cord and placenta. So these are huge complications for labor. Velamentous cord insertion is where the fetal vessels, the fetal blood vessels on the placenta, so they separate at the far end and insert in the placenta away from the margin of the placenta. So that's hard to understand when you're explaining it. So if you look at the pictures in the book, where are the pictures in the book? Okay. So anyways, on page 533, it shows pictures of this. So you can see in that picture, velamentous cord insertion, you can see all those vessels that are that separate, that come away from the placenta. They're all through that margin of the placenta, and they're not they're not encased in that protective covering of the umbilical cord. Okay, so within that umbilical cord is this substance called Wharton's jelly. This is a gelatinous substance that cushions inside. It cushions the vessels in the cord, kind of like the amniotic fluid does in the uterus. So those vessels in that velamentous insertion site, those vessels are not, well, first of all, those vessels should be in the placenta. And number two, those vessels aren't being protected by any kind of Wharton's jelly, okay? So this is a risk for those vessels being severed and causing a massive hemorrhage for both baby and mom. So a vasa previa, just like the placenta previa, previa meaning over the cervical os, those fetal vessels are laying over the cervical os. So you can imagine if someone does a really vigorous vaginal exam and goes up through that cervix and nicks one of those vessels and causes a rupture of one of those vessels, it could be catastrophic for the baby. All right, circumvallate placenta. So we have this double fold, this double ring of amniotic membrane that forms near the surface of the fetal side of the placenta. So you can see from the cord, from the picture in number B, there's that membrane there that's kind of around those vessels, and so that's what we call circumvallate placenta. It's a kind of like just a double fold of the amniotic fluid membranes, the amnion and chorion. That's what the amniotic fluid membranes are. Okay, and so that's very similar to the velamentous insertion. And so that's also, the patient's at risk for a hemorrhage, a massive hemorrhage. So, circensuate placenta. So this is where we have one or more separate lobes of placenta. And where that separate lobe is, then we have communicating vessels from the main placenta to this separate lobe. And those vessels are not contained in any type of cord or Wharton's jelly or anything. So those vessels are at risk for rupture. Now, one of the things is when the person gives birth and they deliver their placenta, sometimes these extra lobes are retained, and these extra lobes do cause postpartum hemorrhage. And then the last one is battledore placenta. So the umbilical cord is in an abnormal, attached to the placenta in an abnormal place. Usually it's attached to the center. This is attached to the edge. And so we do have vessels that span that placenta. And so those vessels are at risk for hemorrhage. Okay. Oh, here's a picture of all those. All right. Now, when we talked about abnormally adherent placentas, we're probably talking about one of these types of placentas. So there's placenta accreta, increta, and percreta. This has to do with the abnormal implantation into the uterine wall. So a placenta accreta has where it has penetrated slightly into the myometrium. Now, the placenta should just be adhered to the endometrium, but if it's gone through the endometrium and now has penetrated into the myometrium is the middle layer of the uterus. The uterus has 3 layers, and the middle layer is the myometrium. And if a placenta has implanted and penetrated into this layer, then it's basically been encapsulated into the uterine wall, and this placenta is very difficult to deliver, to have it release normally from the uterine wall and be delivered without any bleeding issues. So this might be a surgical removal of the placenta, and hopes to salvage our uterus. Okay. A placenta increta is now we have a deeper penetration into the myometrium, and this is definitely probably going to be a surgical removal of that placenta, and hopefully still retaining our uterus. Placenta percreta has completely penetrated through the uterine wall. Okay, and this placenta could now be implanted and adhered to abdominal organs like the bladder or the bowel. And this person is definitely going to be losing her uterus. Okay. And that's what a hysterectomy is. This can cause severe bleeding issues. This is a real problem. They can find these on ultrasound, so hopefully we don't end up with a vaginal delivery and then determine that we have one of these. Hopefully we've found this on ultrasound and have prepared for this. Gosh, how long is this recording? Anyways, anaphylactoid syndrome of pregnancy. This is a very, thank God, rare complication of pregnancy. It was formerly called amniotic fluid embolism, but this is really fatal. The mortality rate is 80%, and of those people who survive, there may be some severe irreversible neurological damage from this. And then, of course, renal problems and liver problems. But what happens with amniotic fluid embolism, for what they think, what they think happens and why this happens in some people and not in others, they don't know. But what happens is there's fetal cells that end up in maternal circulation, and they're calling it anaphylactoid syndrome because they want to relate it to basically an anaphylactic reaction like we have to like penicillin, where we have, an overwhelming respiratory and cardiac shock and we die, okay? There's why some women react and why some don't. They have no idea. But this is really your patient deteriorates right in front of your eyes. Like 1 minute this patient is sitting up, talking to you, laughing and smiling, and the next thing she says is, "Ooh, I feel weird," and then complete respiratory and cardiac arrest. Anyways, oops, I'm sorry. Let me go back. So we have to do whatever we can to stabilize the mom, and then we have to do whatever we can to save the baby. And we have this ethical conflict: save the mother or save the baby. So what we're doing now is we're doing what we call perimortem C-sections. So when people have anaphylactoid reaction syndrome of pregnancy, we're basically doing full cardiac arrest on this woman. So we're doing chest compressions, and we're doing artificial bag valve mask ventilations. And when we start CPR on this pregnant woman, the clock starts. And from the time we start CPR, we need to have that baby delivered within 5 minutes, okay? And preferably within 4 minutes. And what happens is you just basically do a C-section while people are doing CPR on the mom, okay? And then you get that baby out and you hand that baby off to the NICU, and then they do what they can to resuscitate that baby. And then the mom's chances of being resuscitated, now that the baby's gone, I can't remember what the statistic is, but mom has a much better chance of return of ROSC, return of circulation, with that baby being delivered, okay? And so if you do get ROSC on mom, return of circulation, then you take patient to OR, and then you close up her cesarean section. All right. So here's the hypothesis of what's going on, what's causing anaphylactoid syndrome of pregnancy. We just really don't have any idea. We don't really know why some women react and some women don't. It's not detectable. It's not preventable. We don't know when this is going to happen. This can happen when the woman is complete and pushing, or when the woman delivers her baby, or this can happen in the postpartum period. So anyways, so there you go. There's about anaphylactoid syndrome of pregnancy. I've seen it one time in my practice, and it was not good. It definitely wasn't good for baby. Baby didn't make it. They didn't do, at that time, we didn't really know about doing perimortem C-sections. So baby didn't make it, and mom was severely, had severe neurological impairment. She had a lot of liver and renal problems. She was on dialysis, and I know we sent her to Seattle, and actually I'm sorry, I don't know the end of the story. I don't know what happened with her. Okay, but she was in really bad shape. Anyways. Okay, symptoms: acute hypotension. Actually, this woman is going to go into respiratory and cardiac arrest. You might have a few moments of oh, I feel really weird. I feel like I'm going to pass out. And you immediately do vital signs and put her on a pulse ox and see that she's hypotensive and she's hypoxic and then she's out. Okay. If you have time to do that, a lot of times they just say to you, something's wrong. I feel like something's wrong. I feel like something, and then out they go. Okay. It happens that fast. So we need to do ACLS, CPR. If we get the woman back, then we need to, she's going to be in ICU, hemodynamic monitoring. She's probably, she may have hemorrhage. She may go into DIC. She may end up with pulmonary edema. We don't know. So she's going to be managed as an ICU patient. She might have blood replacement products. She might need to be on some type of clotting factors. She may need to, I don't know what kind of craziness would happen if she survived. So like I said, we might end up needing to transfer this patient to a higher acuity care than we can provide at community if they survive. Oh my gosh. Can we just hold on here a minute? I just want to see how many, oh my gosh. So we've got a few more, and I just want to see how long we've been lecturing. Oh, so I've only been lecturing an hour and 30 minutes, so I still have 20 more minutes of total class time. So I'm sure I can do, what, 7 slides in that amount of time? Okay, thanks, guys. So here we go. So perinatal fetal loss, so the death of a fetus or an infant anytime from conception through 28 days after birth. Okay, that's a perinatal loss. So antepartum, so we can lose the baby during her pregnancy. Intrapartum, we can lose this baby during labor, or postpartum, we can lose this baby after the baby has been delivered. Okay, so what do we say to the parents? Or no, before I get there, we need to ask the parents, if we know we're going to lose this baby, or if we've lost this baby, do you want to see the baby? So, if we're going to have a stillbirth baby, a baby that we know that has died in utero, or if we know we're going to have a baby that has anomalies incompatible with life and that this baby will probably die within a few moments of delivery, we ask them, do you want to see the baby? Do you want to hold the baby? Do you want pictures? Do you want prints? Do you want molds? Do you want a lock of hair? Actually, we do all this stuff. We have oh crap, what's it called? Oh my goodness, I'm blanking. We have a, I don't know what it's called. Bereavement. We have a bereavement protocol. And that's, we take pictures of the baby. We have this box that we collect a lock of the baby's hair. We have a special little ribbon we tie it with, and we can take pictures of the baby. Now, depending on how the baby was born. So if the baby was born alive, even if it only took one breath and then died, the baby was born alive, so we have to do a birth certificate, and then we have to do a death certificate. If the baby was born dead, no breath, no heartbeat, no nothing, that's a stillbirth certificate. So we don't have to do a birth certificate. We don't have to do a death certificate. We do a stillbirth certificate, okay? And then what support services does the family need? We'll get social services in there. We might get pastoral care in there, chaplain services. They can contact the funeral home of their choice. The baby can have a funeral just like any person can have a funeral. We put a special sticker on the door so that people don't just walk in there, oh, congratulations, you had a baby. This special sticker does indicate that the baby has died. Definitely we're going to be providing privacy and support for this patient. We're going to, we're going to be present with them. Don't be afraid to hug these patients. Don't be afraid to cry yourself. That's okay to do. All right. But what do we say to these people? What comforting words do we say? One, we acknowledge that it was a real death. So a lot of times Some people who don't know what to say stupid stuff. And they don't acknowledge, well, your baby was never alive to begin with, so people say stupid stuff. So we want to be careful not to say stupid stuff. But you can acknowledge this death. I mean, that's helpful for the parents. They want to know that this was a real event. So acknowledging the death acknowledges that that baby was a person, okay? So comforting words, I'm so sorry for your loss. What was your, do you have a name for your baby? And then use that name for the baby. Things like that. Things not to say. It is God's will. Do not say that. You can have another baby. Don't worry about this. Don't let this upset you. You can have another baby. It's okay. There was a problem with this baby, so you should be happy this baby died. The baby didn't suffer, and you didn't have a whole life of taking care of an invalid child. Don't say things like that. There's always next time, okay? Don't say things like that. Thank goodness you never were attached to this baby. Well, yeah, they were. From the time it was conceived, they were attached to this baby. So think about things you're saying. And if you don't know what to say, don't say anything. Be with your patient. Now that I've said that, there might be a test question, and one of the things is don't say anything. That's not the correct thing to say. If you know something to say, and something you can say is, I'm sorry for your loss. I'm sorry for Toby's death, or whatever the baby's name was. I'm sorry your baby died. You can say, I'm sorry, okay? So that is something that you can say. Now, depending on what culture this patient is from, there might be loud outbursts, screaming and chanting. So, for instance, the American Indian population, there is a lot of screaming and chanting. So don't try to quiet them. Don't be like, oh, you're being too loud. Don't be like that. Let them be what they need to be. Okay. Some may be very quiet where you're worried, like, do they even realize what just happened? That may be a cultural expectation of how they're supposed to deal with this death. Definitely you don't want to allow people to be banging their heads against the wall or pulling their hair out or running and screaming and shouting through the hallways. We can't allow things like that to happen. But in the patient's room, as long as everybody's safe, whatever their practice is for dealing with death in their culture, we need to allow. Now, cesarean births, they can be a complication. Cesarean birth is a surgery, and surgeries do have their risks, okay? But we will do a cesarean birth for the health of the mother or the health of the baby. If it's better for us to do that than allow for this labor to continue or a vaginal birth. Now, and also C-sections can be done as primary C-sections or repeat. Primary means it's the first C-section the woman's ever had. Of course, a repeat C-section means she's had C-sections before, but she can also have an elective C-section. She can just say, hey, I've thought about it. I really don't want to have anything to do with labor and a vaginal birth, and I choose to have a cesarean section. That is her choice, and we can allow her to do that. What are the risks for a cesarean birth? Well, a risk for surgery is a hemorrhage. So that's a risk for surgery and a cesarean birth. A thromboembolism or blood clots, that's a risk of surgery, and that's a risk of a cesarean section. Infection, a risk of any kind of surgery, a risk for a cesarean section. Of course, pain. Because the cesarean section is taking place near the bowel and the bladder, we can possibly injure the bowel and the bladder. We could cause adhesions, and which will, in the future, cause pain for this woman after she recovers from her cesarean section. A dehiscence, an evisceration or dehiscence, is a risk after having a cesarean section. For future pregnancies, she could have now placental problems. She can have one of those percreta, increta, accreta problems. Or she could have an abnormally implanted in an abnormal position, not abnormally adherent, but an abnormally placed placenta because of scar tissue from a cesarean section. And of course, mom can have respiratory problems depending on what kind of anesthesia we use, but definitely a respiratory problem for a baby because they don't go through the birth canal and they don't get that thoracic squeeze that helps them eliminate some of their fetal lung fluid, and that also helps stimulate their first breaths. So they may start having respiratory problems. There's different kinds of cesarean sections as far as the surgical incision. The two main ones that we're going to talk about is the classic, that is a vertical incision on the woman's abdomen. Or there's the lower transverse cesarean section, or a Pfannenstiel or bikini type cesarean section. The classic is reserved for the absolute, beyond a shadow of a doubt, a total emergent cesarean section. It's the fastest way to access the uterus and get the baby out. Okay, is the classic. We totally reserve that for the absolute, beyond a shadow of a doubt, we need to do a classical cesarean section. But most of the times we will do this low transverse Pfannenstiel suprapubic incision, okay? There's less blood loss. We have fewer infections. There's fewer dehiscence and evisceration problems, and decreased likelihood of uterine rupture because the incision is so low on the uterus and contractions start so high on the uterus that women do have the opportunity to try a vaginal birth after this cesarean section. However, if they have the classic, they have no opportunity to try a vaginal birth after cesarean section. The next time I see you guys, ask me about the anchor cesarean section. It's not a real thing. It is kind of sort of a real thing, but it's not a real thing. So ask someone, remember to ask me about an anchor cesarean section. All right. So we handle this patient like a surgical patient. We do post-op care just like a surgical patient, with the added assessments of her bubble heat and care of her baby. Okay. And then she can have a vaginal birth after cesarean section. It's called a VBAC, VBAC. And that's actually an old term. The new more politically correct term is TOLAC, TOLAC. It's trial of labor after cesarean. That's more of a politically correct terminology, because we're actually, for a woman who wants to do a VBAC, we're actually trialing to see if she can labor. And if she can labor, then she can probably have a vaginal birth. So it's actually more politically correct to say TOLAC than it is to say VBAC. All right? Okay. Anyways. So her post-surgical care, well, I'm sorry. So pre-op care is, we'd like them to be NPO 6 hours before the C-section. So if you have this labor going on, she's been laboring all day and you've been letting her have Jell-O and some saltine crackers, she might not be NPO for 6 hours, and we're not going to wait if we need to do an emergency C-section. But if she's a scheduled C-section, we're going to tell her nothing after midnight, okay? And then come in the morning and we'll do your C-section. A lot of times we have them do a special shower at home before their cesarean section. But whether they do that or not, we are also going to do an abdominal wash when we get her in to our unit and we're doing our pre-op stuff. Okay. But anyways, we're going to draw a CBC and a type and screen. We're not going to do a type and cross. We're going to do a type and screen just like we would do for a vaginal delivery. We're going to do a non-stress test. Basically, that's just to put the baby on the fetal monitor and make sure baby's heart rates look good. But we'll talk more about non-stress tests in another lecture. we're going to start our IV and we're going to give her a fluid bolus for the first liter, and then the second liter can just be at a slow drip. We're going to do a small strip of pubic clip. We're going to do a Mons pubic clipper shave, a small strip on her upper Mons or suprapubically. Okay, and again, we're going to do the abdominal wash. We're going to put an indwelling Foley catheter, but we do that after she's gotten her spinal. But when we head to the OR, so we do our prep, and she may be sitting in the pre-op room for an hour before we go to OR. But on our way to OR, we're going to start an antibiotic. It is the, what does that stand for? It's the surgical decreased surgical infection protocol, where you give antibiotic 30 minutes within 30 minutes of incision. So we do that right when they're walking to the OR, and then that antibiotic's in before the incision is cut. Most of the time we will end up giving her Pepcid, Bicitra, and Reglan, depending on what the anesthesia wants. These medications decrease gastric acidity and increase gastric emptying. And so that just helps the anesthesiologist when they have this woman laying flat on the surgical table to reduce gastric regurgitation and aspiration, gastric aspiration. So that's why that's given. Okay? And then off to surgery she goes, and she gets her spinal. We will check the fetal heart tones real quick after she's gotten her spinal, just to make sure baby's still doing well. Again, we'll put in that indwelling Foley catheter. We'll do a sterile surgical scrub on her belly, and then we lay her down, and she well, we laid her down already, and then she's ready to be draped and have surgery. And then so the labor nurse now becomes the circulating nurse, and then the OB, labor and delivery charge nurse, comes in and is the baby nurse and does all the baby cares. Now post-op, she goes to PACU, which we now recover our patients in OB. And so that's just recovering from anesthesia. It's usually about 45 minutes where we make sure they have a patent airway. We make sure that they're breathing okay, that they have good oxygen saturations. We put them on a cardiac monitor and make sure they have good cardiac rhythm. We monitor their vital signs very frequently. We're checking her fundus and lochia very frequently. We're managing her pain if that might be an issue in there. And then we're doing this very often for about 45 minutes. And then when she meets criteria, she can be discharged from PACU and admitted to postpartum. But in PACU, baby comes in, and baby can be skin to skin and breastfeed during our PACU recovery. Okay. Oh, here I've talked about the TOLAC. Okay. All right. So the criteria for allowing the patient to have a TOLAC is that they have that low transverse incision. If they've had a successful vaginal birth previously, that's great. But if they've had a successful vaginal birth after cesarean, then they can continue to have vaginal births. And that lets us know that they have an adequate pelvis to deliver. And then they have no other uterine scars or anomalies. We'll let them do a TOLAC. But if we have a patient that's doing a TOLAC or VBAC, then the entire surgical team has to be in-house throughout her entire labor. Okay, so that irritates some of the surgical people. But that is part of the national standard. Post-term pregnancies are pregnancies that extend beyond 42 weeks. And really, like we say that term is 40 weeks. So from 40 to 42 weeks, we have this little grace period of what normal term is. But if they go beyond 42 weeks, then they're called post-term. Those babies are at high risk because that placenta was only designed to live for 40 weeks. So that placenta is going to start having sufficiency issues. That placenta is not going to be adequate for exchanging nutrients to the baby. And that placenta is going to start having areas of infarct, and they're going to start calcifying and have clotting fibrin clot type, scabby type deposits, and those places of that placenta are non-functional. Okay. The other thing with the babies that go beyond 42 weeks is these babies they can be severely huge babies. So the closer you get to a 3-month-old baby, the bigger the baby is, right? Well, that's kind of an exaggeration, but these babies, can get bigger, but because of this placenta problem, this aging placenta problem, we see a lot of dysmaturity syndrome or wasting syndrome of our babies, where they look like wrinkly little old men, where they start having muscle wasting syndrome, basically. But anyways, with the big baby, we run the risk of shoulder dystocia. We run the risk of injury to the baby being delivered. These babies also can be at risk for oligohydramnios, not enough amniotic fluid, meconium staining amniotic fluid. Babies can have fetal distress and all kinds of things. We can have stillbirth babies because of this placenta problem. You have a placenta that's so dysfunctional that it might, these patients might be home at 42 weeks and that placenta says, I'm not doing good enough. And your baby says, I'm dying here. And then the baby actually does die. Okay. So we can have all these problems with someone who's been pregnant too long. And then, of course, if her baby is so big, mom is at risk for a lot of problems. Okay. So if we have a baby that's 42 weeks or older, then someone and talk this woman into an induction. That's usually the problem. The woman is refusing induction. So there's no OB that wants to wait 42 weeks before inducing a patient. They all want to induce them too early. They don't want to induce them too late. It's the patients who are refusing this induction if they don't go into labor on their own. And there's some women who don't go into labor on their own. I was one of them. And so I was 42 plus weeks before I delivered my child. And he was one of those big 3-month-old babies that was born with an emergency C-section. So anyways, so if we have a woman who is postdates, then we're going to do this antenatal testing. What that means is we're doing things to look at fetal well-being. So every day we're going to tell this woman, you need to do daily kick count several times a day. If your baby is not kicking often enough, then we're concerned about your baby. Healthy babies move. Healthy babies are active. Sick babies do not move. So if her baby starts having problems, she's going to stop feeling baby move. We will do an NST. This is another way we can determine if babies are doing well. We have to do this every week. And, and I would even venture to say do this twice a week. We're going to look at our amniotic fluid volume, making sure that we have enough fluid volume in there. And then maybe do a biophysical profile. This is another test that we can do on the baby to make sure baby's doing well. Biophysical profile is basically an ultrasound to look at some different things about the baby, plus an NST. So those are things to tell us about fetal well-being and whether or not our baby is doing okay. But we're going to want to induce this woman. We don't want to let people go 42 weeks before we start talking about induction. We want to talk about this before and say, we don't want to let you go to 42 weeks. So if you're 40 weeks, we need to start having this, when are we going to do your induction conversation? Okay. All right, end of slideshow. I'm not going to talk about the pain chapter because this is enough for one lecture. And so please write down your questions. I hope you were taking questions, writing questions all throughout this lecture. But anyways, we will talk again. I'm 3 minutes past due. All right, guys. Thank you. See you next week.